This recording will cover part 2 of congenital heart disease and will focus on heart failure. The earliest manifestations of heart failure are often subtle. Mild tachypnea, 70 to 100 breaths per minute at rest, and difficulty feeding are present in some infants. Parents may report that feedings take longer and the child requires frequent rest periods. This type of history describes a scenario in which fewer calories are consumed, even though metabolic demands are increased. Therefore, feedings provide little satisfaction, and the infant may appear hungry and irritable soon after feeding. Over time, the infant fails to gain weight and eventually develops a condition known as failure to thrive. Children with heart failure also exhibit respiratory-related symptoms. Some complain of dyspnea, particularly on exertion, and tachypnea. They are often described as having less energy than their peers, and they may exhibit diaphoresis and complain of decreased appetite. These symptoms are caused by chronic abdominal pain, usually related to poor circulation and decreased perfusion to the abdominal organs. This condition can also prevent normal weight gain. Other clinical manifestations of heart failure include abnormal cardiac rhythm, periorbital and facial edema, neck vein distension, hepatomegaly, splenomegaly, decreased peripheral perfusion, decreased urine output, mottling, cyanosis, and pallor. The diagnosis of heart failure is based on clinical history, physical examination, chest radiographic appearance, ECG, and echo. Chest x-rays can reveal cardiomegaly with increased pulmonary vascular markings. Lab studies used to determine the presence of heart failure in children include determinations of arterial blood gas values, serum electrolyte values, complete blood cell count, erythrocyte sed rate, serum glucose and calcium levels, and urinalysis. Management of a child with heart failure involves correcting the underlying problem as soon as possible. The medical management of heart failure is directed towards decreasing cardiac workload and improving cardiac output through the manipulation of hemodynamics and neurohormonal responses. Supplemental oxygen can be helpful for increasing oxygen saturation, but it should be used with caution in children with left to right shunts because oxygen is a vasodilator. It can increase pulmonary blood flow. Pharmacologic agents used include positive inotropes such as digoxin, diuretics, ACE inhibitors. Digoxin is now used less frequently in favor of ACE inhibitors because of the risk of toxicity. In addition, optimizing nutritional intake to meet the metabolic demands and improve growth is of paramount importance. A persistence of symptoms and lack of weight gain are indications for surgical intervention. So we'll talk about the meds here a little bit. So digoxin is a cardiac glycoside that increases cardiac output and improves cardiac effectiveness. It is a positive inotropic, and if you remember inotropic, a positive inotropic would mean a better squeeze of the heart or increased myocardial contractility, right? So digoxin has positive inotropic effects, negative chronotropic effect, meaning it decreases heart rate. So chrono being like chronological numbers and negative being turned down. So positive inotropic, a better squeeze, negative chronotropic, slower heart rate. And what that does is it allows the heart to push blood out more effectively and at the same time slows down the heart rate. So that leaves more time for diastole and for better filling of the ventricles before that more effective squeeze of the heart occurs. Let's see. It improves blood flow to the kidneys and enhances diuresis. Obtain a baseline ECG before initiating digoxin. Loading or digitalizing dose according to the child's age and weight is administered in divided doses over 12 to 18 hours, and maintenance doses are given daily, usually in 2 divided doses. The range between the therapeutic and toxic digoxin level is narrow, with the therapeutic range being between 0.8 and 2. To avoid a falsely elevated serum dig level, serum digoxin levels should be measured at a minimum of 6 hours from the previous dose. Levels are generally obtained when assessing for toxicity or medication adherence. If a child is receiving digoxin and is having dysrhythmias, the dig level should be measured. Hypokalemia and hypomagnesemia can increase the risk for dig toxicity. Diuretics are administered to eliminate excess weight and sodium through increased urine production, thereby reducing systemic and pulmonary congestion. Furosemide is a potent loop diuretic and is preferred for initial diuretic therapy. Another class of diuretics, the thiazides, acts on the distal renal tubules. These can be less potent than loop diuretics. These drugs cause the kidney to waste potassium, placing the child at increased risk for hypokalemia. Spironolactone you should recognize as your potassium-sparing diuretic, and it is a weak diuretic. This class of diuretics is often given with loop diuretics or thiazides to decrease the potential for hypokalemia. Potassium supplements can also be given in tandem with diuretics to replace losses. Vasodilators such as hydralazine or captopril or enalapril, those prils let you know you're dealing with an ACE inhibitor, work by relaxing smooth vascular muscle and reducing afterload. Your textbook has a nursing care plan for the child with heart failure, as well as parent and patient teaching boxes about giving the child digoxin, another box about feeding the child with heart failure. So there's a lot of information. I'm going to hit some high points, but you're responsible for reviewing those boxes on your own. So under the nursing care plan, it talks a little bit about monitoring the patient, so observing and documenting peripheral perfusion and palpating peripheral pulses, noting temperature, color changes, cap refill, because poor peripheral perfusion is usually evidenced by decreased or absent pulses in the extremities. Color and temperature changes may be present in all extremities, and prolonged cap refill time is an additional sign of poor perfusion. Monitor heart rate because tachycardia occurs in an attempt to maintain adequate cardiac output. Altered renal perfusion caused by decreased cardiac output results in decreased urine output, so we're watching urine output. Episodes of hypothermia or hyperthermia increase oxygen demands and increase cardiac workload, so you want to maintain a neutral thermal environment for the patient. And then time nursing interventions to allow the infant or child rest periods. Rest periods reduce cardiac workload. In regards to administering digoxin, you've learned this in a farm. You want to get a full minute of apical heart rate. Here's the big difference. With adults, right, we hold digoxin if the heart rate is less than 60. With children, we're going to hold digoxin if the heart rate is less than 100 beats per minute. Remember that the therapeutic range for digoxin is 0.8 to 2. Dig toxicity can manifest as bradycardia, vomiting, and dysrhythmias. When a child is receiving diuretics, we want to use the same scales and weigh the child daily at approximately the same time, as well as notify the provider of any excessive weight gain. In infants, that would be greater than 50 grams per day, and children greater than 200 grams per day. Also want to monitor potassium levels, as certain diuretics like loop diuretics and thiazides can cause hypokalemia. In regards to monitoring nutrition and promoting nutrition in the child with heart failure, you want to weigh the infant or child daily before, and after each feeding for breastfed infants using the same scale. Breastfeed or feed smaller volumes of concentrated formula every 3 hours. The increased caloric content of formula increases caloric consumption and enhances weight gain. Use a nipple that the infant can comfortably adjust the flow rate and energy to express milk. May need a soft, large hole nipple. Infants with heart failure tire easily. An appropriate nipple for the infant minimizes the level of energy required to express milk at a rate of flow the baby can swallow comfortably. A soft nipple with a large hole may facilitate easy sucking and decrease energy expenditure during feeding. Time the feedings to allow for adequate rest. Every 3 hours is a frequently used interval. In regards to parent teaching about digoxin, digoxin is usually given every morning and evening. Give digoxin 20 to 30 minutes before a feeding. The amount of digoxin you give must be measured carefully with a syringe, not a dropper. This is caregiver teaching. You want to put a few drops of digoxin in the child's mouth and let the child swallow before giving more. If you forget to give your child a single dose of digoxin, give the dose when you remember and then resume your original schedule. If your child vomits, do not repeat the dose. Resume the digoxin at the next scheduled dose. If you miss or your child vomits 2 doses in a row, call the cardiology department. Rarely, children have too much digoxin in their body and can have vomiting. If your child vomits, call the pediatrician or cardiologist. Keep digoxin in a place where the child living or playing in your home will not be able to reach it. If someone accidentally takes digoxin, call poison control. or take the person in the DIG bottle to the emergency room and obtain refills at least 1 week before you're out of medicine, and ask for new prescriptions as needed. For teaching regarding feeding of the infant with congestive heart failure, feed the infant or child in a relaxed environment. Time the feedings before multiple other activities to preserve the infant's energy. The infant with heart failure tends to tire easily during feedings. Frequent small feedings can be less tiring. Hold the infant in an upright position, causes less stomach compression, and improves respiratory efforts during feeding. If the child is unable to consume an appropriate amount during a 30-minute feeding period every 3 hours, NG or ND feedings should be considered. Assess for increased tachypnea, diaphoresis, or feeding intolerance. Concentrated formula from the basic level of 20 kilocalories per ounce to 30 kilocalories per ounce or higher can increase caloric intake without increasing the infant's work. Remember to educate parents on signs and symptoms of heart failure, increased cyanosis, dehydration, infection, dysrhythmias, decreased nutritional intake, and any medications the child is receiving.